ਇੱਥੇ ਹੀ ਹੋਇਆ।
इस टाइम बायोप्सी का नहीं हुई आपकी?
नहीं, बायोप्सी पहले हुई है, 3 दफा एंडोस्कोपी हुई है, उसके बाद नहीं हुई क्योंकि पैसे भी बहुत घट गए।
अच्छा, मोशना ਨੂੰ ਆਰਾਮ है बेहतर चल रहा है इलाज?
हाँ जी।
अच्छा जी, ਤੁਸੀਂ 3 ਸਾਲ ਪਹਿਲਾਂ ਆਏ ਸੋ ਠੀਕ ਹੈ ਤੇ ਉਹ ਐਂਟੀ ਸਾਲਾਂ ਦੇ ਵਿੱਚ ਕਿੰਨੀ ਵਾਰ ਦਾਖਲਾ ਹੋ ਚੁੱਕਿਆ ਹੈ?
पहले तो थोड़ी दफा ही होया, हूँ तो 15 दिन मनांगे, 15 दिन 8 दिन हो जाते, फिर इस तरह ही हो जाते। इससे पहले मैं छुट्टी लेके गई थी, डेगू का खत्म सी साल का, उदो लैके गई थी, मैं कई दूसरे से बाद आवांगी। उस बाद फिर 2-3 दफा ऐसे ही हो गई, फिर एमरजेंसी लैके आई फिर उधर की फिर मैं हूँ एक बार फिर इधर लैके आ गई। उधर
अंदाजा कितनी को बार दाखला हो गया है?
ऐसा हो ही गया कोई
आखिरी साल ਦੇ ਵਿੱਚ ਕਿੰਨੀ ਕੁ ਵਾਰ ਹੋ ਗਿਆ ਹੈ, ਕੁਝ ਯਾਦ ਹੋਵੇ? ऐसे ਤੁਸੀਂ ਕਹਿ ਰਹੇ 15 ਦਿਨ ਅੰਦਰ 15 ਇਹ ਕਿੰਨੇ ਚਿਰ ਤੋਂ ਇਹ ਇਸ ਤਰ੍ਹਾਂ ਦਾ ਚੱਲ ਰਿਹਾ ਹੈ?
ਇਹ ਸਾਲ ਤੋਂ ਇਸ
ਤਰ੍ਹਾਂ ਚੱਲ ਰਿਹਾ ਹੈ। ਪਹਿਲੀ ਵਾਰ ਜਦੋਂ ਦਾਖਲ ਹੋਏ तो ਉਸ ਟਾਈਮ ਕੀ ਟੈਸਟ ਹੋਈ ਸੀ ਇਹਦੇ? यूरिन टेस्ट और ठीक है, एंडोस्कोपी भी हुई थी सर? ठीक, कदे बेहोश हुई हो या कदे कोई होश खराब हो गई हो, झटके दौरे पे हो या रात के टाइम नींद ना आती हो, सवेरे सौंदी हो?
रात में सो रही थी, नींद बहुत ज्यादा है।
अच्छा जी, स्कूले जाती?
हाँ जी, स्कूल जा रही थी।
अच्छा,
6वीं तो एक बीमार हुई है, तो उस बाद 6वीं की, 7वीं की, 8वीं हुई है, तो फिर उस बाद मैं हटा दी क्यों जो 8वीं की तो ज्यादा तौर पर अस्पताल ही रहती थी, तो फिर मैं
हस्पताल तो अलावा पढ़न दे विच कोई मसला आंदा होए?
पढ़ाई तो एडी अच्छी चल रही थी, सारी
पढ़ाई कदे भी खराब नहीं हुई?
कभी खराब नहीं हुई।
पेंशन फाड़ के जो पेंसिल वगैरह जब आप पकड़ के लिखते हो उसमें कोई मसला तो नहीं आता? पकड़ लेते हैं ठीक तरह से? चिड़चिड़ी रहती हुए या बहुत ज्यादा गुस्सा करती हुए?
पहले नहीं करती, हुण शुरू हुण गुस्सा करती है।
आदत बदलियां हैं कि नहीं बदलियां? ऐसा कुछ महसूस किया?
कोई ऐसी नहीं है, फिर मैं जरा गुस्सा कर जाती है।
अच्छा, अच्छा, जिसम से कोई दाने निकलते हो या कोई एलर्जी हो जाती है?
साल पहले खारिश हुई थी।
खारिश से?
हाँ जी।
दाने की खारिश से?
हाँ जी।
रात के टाइम ज्यादा होती है?
दिन में हो जाती थी, रात में।
अच्छा, नहीं दानिया तो अलावा धुप्पे निकलती हुए साड़ पै जाता हुए या वाल उतरते हो, मुंह के छाले बनते हो? अच्छा, ठीक है, या जोड़ सुझते हो? कदे खून तो आया हुआ है?
हाँ जी,
साल हो गया? कितनी बार लगा? एक दफा ही लगा, बार बार तो नहीं लगना? ठीक, और टेस्ट शुदा खून तो आया सीगा किधरों आया? इधरों के इमरजेंसी से लगा? मुझे कारीगर कान के टेस्ट हुए, कान छिदवाए नहीं कि नहीं मुझे? आप का काले या कान का टेस्ट होया? बचपन से बीमार रहती हुई
बचपन से कभी बीमार हुई नहीं थी
किसी भी तरह का
ना कभी भी नहीं
यकान बहुत ज़्यादा रहा है पैदाइशी तौर पर जो यकान होता है बहुत ज़्यादा रहा है कोई ऐसी गल
नहीं तो होया नहीं
पोटियां लगियां हो या छाती खराब होती है
कभी क्यों पैदा हुई है ते 11 साल में कभी बुखार है
अच्छा तो मेरा इलाज चल रहा है वो किस सूरत से चल रहा है टीके चल रहे हैं बीमारी में तो जो है जिगर बढ़िया आएगा ਤੇ ਕੀ ਗੋਲੀਆਂ ਸ਼ੁਰੂ ਕੀਤੀਆਂ ਟੀਕੇ ਨਾਲ ਇਲਾਜ ਹੋ ਰਿਹਾ ਕਿਵੇਂ ਹੋ ਰਿਹਾ इधर तो इंजेक्शन लग जाते हैं घर के लिए आपको क्या देते हैं ठीक है ओके और मेडिसिन ठीक है मेडिसिन कौन से वाली होती है कितने किस्म की कुछ याद है आपको कैसे कैसे लेते हैं जब कितने किस्म की होती है एक ही किस्म की गोली है या क्या है
नहीं 3-4 किस्म है गोली
ठीक है तो कितने टाइम लेते हैं वो कुछ याद है
3 टाइम कोई 2 टाइम
ठीक है चावल के दाने वाली छोटी पतली सी गोलियां वो भी हैं कि नहीं वो नहीं है
नहीं
वो नहीं
नाम तो याद है अच्छी गली नहीं कभी खून जारी हुआ है किधरों नाक ठाणी या पखाने वाले रास्ते पेशाब वाले रास्ते नहीं कभी नहीं
समझे नींद का निशान पे हो नींद
नहीं
जल्द बहुत ज्यादा यदि खुशक होती है
हाँ जी दिल से खुशबू नहीं है
हड्डियां से दर्द महसूस कर दी चलन फिर जो कोई मसला होता है या थोड़ा जा
चलती फिरती वैसे कह रही कि मेरे लक्षण में दर्द होती
और कोई ठीक है तो नील बिल्कुल नहीं करते
नहीं
दवाइयाँ इस्तेमाल करते हो या कोई एलर्जी वगैरह हो गई हो कदे
नहीं एक दफा इधर दवाई लै रहे थे कि वो इन्हें दवाई टीका लगा सी तो उस टाइम जरा कह रही थी कि मैंने जिस तरह खारिश नहीं होंगी उन्होंने फिर चेंज कर दोबारा टीका लाया और तो फिर ठीक हो गया
बंद करके लाया सी कि कट करके लाया सी टीका
नहीं उसको अलावा ना टीका छोटा भर के लाया ना सिरिंज
जी जी
ਉਹਦੇ ਨਾਲ ਐਲਰਜੀ ਹੋਈ ਇਹਦੇ ਨਾਲ
ਅੱਛਾ
ਉਹ ਫਿਰ ਇਹਨਾਂ ਨੂੰ ਦੱਸਿਆ ਹਾਂਜੀ ਉਹ ਫਿਰ ਦੁਬਾਰਾ ਟੀਕਾ ਲੱਗਾ
तो
ਫਿਰ
पूड़ियाँ साशे भी दे रहे हैं
ਹਾਂਜੀ ਜਿੰਕ ਵਾਲੀਆਂ ਕੁੜੀਆਂ ਜਿਹੜੀਆਂ ਉਹ ਵੀ ਦੇ ਰਹੇ ਤੇ ਸ਼ਾਸ਼ੇ ਜਿਹੜੇ ਉਹ ਵੀ ਦੇ ਰਹੇ
अच्छा कोई ग़िज़ा दे विचों कोई परहेज़ दसी होए
ਗੱਲਾਂ ਸ਼ਾਮਾਂ
और इस तो अलावा
ਤੇ
शाबाश और
और गुजार की ये ले गया
अच्छा ठीक है और कोई बादाम वगैरह या इस तरह की चीज़ें वो मना है ठीक है और बर्तन किस में पका के खाना है वो बताया कि किस में नहीं बना के खाना तांबे के बर्तन इस्तेमाल नहीं करने को ऐसी बात की आपको चेक करें यहाँ लेटते हैं बेटा हाँ करके चप्पल उतारें थोड़ा चप्पल उतारें शाबाश ओके किधर यहाँ पर पैर जोड़े आपस में, पैर जोड़े, सामने देख। हाँ जी, बैठिए। Sir, I would like to know the weight of the patient. यहाँ बेटा इधर बैठ। पैदाइश नॉर्मल थी, कोई मसला मसाइल या कोई दाखिला होया है या खून तब्दील करना होया है, हफासिटी के सारे लगे सर, कोर्स कराया सी, कार्ड बन गया, ठीक है, शाबाश। रोजाना नहीं, बस थोड़ा सा चेक करना आपको, ठीक है। कितने में आ रहे थे? ये खानदान में किससे हुआ मसला इस तरह का? ये अपने यहाँ जो होया गहरा किधर का? So the clothing is very tight. I'm not able to. Am I allowed to take the blood pressure from top of the clothing? सीधा क्यों बैठे? वैसा फी कम कर देंगे। अच्छा एक आधा बच्चा कौन बर्दाश्त कर दे?
बेटे ही रहते हैं, थोड़ा बच्चा तो बेटे अभी खाती नहीं है और भी कुछ करता दे
शाबाश, बोले हाँ, क्या हो गया? अंदर मूवमेंट के लिए कैसे करते हैं? शाबाश। तो सोफा करके फिर चेक करना, ठीक है? बस इससे आप ऐसे करेगा, शाबाश। सर्दी नहीं लगी? दोनों मुझे बताना है आपने, ठीक है? वैसे होगी नहीं आपको। लंबा सांस लें। नीचे करवट लें। लंबा सांस, जोर से। सब करवट लें। I'd like to complete my examination.
3 minutes.
Number 3. उठ के बैठिए। शाबाश।
definitely start now.
My patient Aisha, 14 year of age, a resident of Lahore, admitted for the past 5 days through outdoor patients department at tertiary care hospital.
Patient name is
Alisha. With the complaints of loose motion for the past 2 days and fever for the past 2 days. The motions were 4 to 5 per day, copious in amount, foul smelling, grade 4 to 5 inconsistency with no mucus or blood, and no tenesmus was reported. Fever was not documented and was reported to be approximately equal to 100 degrees Fahrenheit with no abdominal pain and no jaundice at the moment. She has been investigated in the form of some blood tests and some urine tests and is currently on injectables with improvement of the symptoms. My patient is a known case of chronic liver disease for the past 4 years. And for the last 3 years, she has been on regular follow-up in the tertiary care hospital. The complaints that she was in usual state of health when 3 years ago, she started developing abdominal distension, which was reported to be for the past 7 days, gradual in onset and generalized, and associated with no history of any yellowish discoloration of eyes or dark colored urine. The urine was reported to be brownish, but not specifically dark colored urine as in no history of oliguria, urinary complaints or cola colored urine. Since that time there has been multiple admissions. The frequency of admissions have been increased in the past 1 year. The patient has no history of any post-school performance, no fine motor or gross motor delays, no personality changes, however mood swings are reported. There is no history of any oral or nasal ulcers, any arthritis, any rash, any alopecia. There is no history of repeated transfusions. She has been transfused 1 time with the proper screening, and there is maternal screening for hepatitis B and C as not done. There is no history of previous illness in the form of any loose motions or repeated chest infections or any malabsorptive stools. Currently, the child has repeated complaints of tetanic spasms. However, there is no history of any encephalopathy, no bleeding, no rash, and the skin is reported to be dry with bone pains. However, there is no history of any ataxia or bruising reported by the family. And there is no history of any respiratory distress as well. Currently, she has been on some medications which the patient does not know of. These are oral medications, and some sachets are given. And investigate, and the patient has poor knowledge regarding the total prescription given to her. She is a product of consanguineous marriage, fifth in birth, however, no family history of any jaundice or liver-related diseases. She is, the birth history is uneventful. She is vaccinated according to EPI, and they do not know any dietary, they cannot recall any dietary restrictions which are disease specific. And they belong to poor socioeconomic status with demise of the father, and brothers are the only bread earners. The disease has significant impact in the form of vocational loss in the patient. However, avocational is intact, and the education regarding the disease, its treatment options is poor. However, follow-up is adequate. On examination, she is a thin, lean, emaciated girl with pale complexion and having a height of 143 centimeter and a weight of 30 kg. Weight lies below 25th and 50th centile, and the height is at the 50th, slightly above the 50th centile. She has a pulse rate of 102 beats per minute with a respiratory rate of 19 breaths per minute. Currently afebrile with temperature of 96.4 degrees Fahrenheit and a blood pressure of 100 by 55 millimeters of mercury. She is pale, having no evidence of any jaundice, cyanosis, digital clubbing, lymphadenopathy, pedal edema. Bruises are there at the prick site at the right wrist, which are insignificant, and no other rash on the extremities and the upper part of the chest. There are xanthelasmas under both the eyelids, more marked in the under the left eyelid, and apex beat is in the fifth intercostal space on the left side, with first and second heart sounds normal, and upon extension of my examination, abdomen is soft, non-protuberant, with liver which is palpable 7 cm below the right costal margin, upper border in the 6th intercostal space with a total span of 10 cm. Left lobe is not palpable, it is non-tender, smooth surface and rounded margins. No other viscerals are appreciated. There was no fluid frill, and the back of the child was normal. She has apparent thelarchy in the form of SMR stage 1. I wasn't able to do the genital examination, and rest of the systemic examination is unremarkable, sir.
You examined the abdomen, and there is no left lobe. The total span of liver is 7 centimeters below.
Explain the name.
The full 14 years.
This is not differential with the patient. Patient knows everything. You can ask from the patient. He knows treatment. I know that disease. And when you examine the patient, you have not offered or asked for CT. You should keep the patient.
Should have asked.
लेफ्ट लोग निकले वैसे यार मोटरसाइकिल का जाए वैसे ही कॉल है सर को भी ना मैं वक्त वैसे कर रहा हूँ जो जीएडी में भी अंदर भी तो मुझे मोटरसाइकिल left lobe.
What is your diagnosis?
Sir, in this case, I would like to offer differentials of chronic liver disease. My first differential would be Wilson's disease, followed by autoimmune hepatitis,
ओके सबसे पहले हिस्ट्री डिस्कस कर लेते हैं अपना The patient told you that she has yellow colored urine, but in history you said that there is no yellow colored urine. And you have asked about vesicular urine. What is the significance of vesicular urine?
Sir, the patient complained of periorbital puffiness. I wanted to rule out the renal causes.
Renal causes. Okay. And what is the significance? And what is differential when you ask about vesicular urine? You have labeled it as a chronic liver disease. You are going to discuss the differential of chronic liver disease. What is the significance of this vesicular or collateral urine regarding chronic liver disease?
Sir, it is not related to chronic liver disease, but I wanted to rule out atypical nephrotic.
Atypical nephrotic. What are the other causes of vesicular, or you can say hemoglobinuria?
Sir, sir, only atypical nephrotic was in my mind, so I pertinently asked for that only. Due to periorbital puffiness reported by the patient.
Why is there is vesic or collateral urine?
So there was no history of collateral urine.
Then what are the causes which lead to vesic or collateral urine?
Sir, dark colored urine was reported, but I specifically asked whether it was yellowish discoloration. The patient reported no, it was only the hyperosmolar urine.
Why do you have asked what is the significance of headache?
Sir, again, I wanted to rule out the nephrotic as part of my differentials.
Differential. And
It was ruled out.
The patient is coming again and again to us with complaint of carpopedal spasm from the last 1 year. What is the reason in this patient of carpopedal spasm?
Sir, currently the child is underweight, and number 2, vitamin D deficiency leads to hypocalcemia, and usually that is refractory in the CLD, and that can lead to tetanic spasms.
What other condition can lead to tetany?
In my index case, sir, this is the only cause I am able to ascertain.
What other causes can be? What are the possibility in chronic liver disease? Why there is hypocalcemia, hypovitaminosis D? What condition will lead to?
Sir, there could be nutritional causes,
Okay.
and there could be disease-related causes,
Okay.
and I'm not sure, but sir, due to chelation, probably hypocalcemia. I'm not sure about this one.
Chelation. Is chelation lead to hypocalcemia?
No, sir, I'm not sure, sir.
What it can lead to?
Sir, it can lead to. No, sir, not specifically this hypocalcemia, but
You have asked about unconsciousness states. What is the significance of that?
sir, I wanted to inquire about the encephalopathy.
And skin rash, joint swelling, oral ulceration.
Skin rash for thrombocytopenia, and specifically for rash in autoimmune hepatitis and joint swellings in reference to autoimmune hepatitis.
Okay. And the patient remained in periphery for 1 year. And what treatment he has took there?
So she was not admitted and took OPD medications from different clinics, but the mother does not recall the details about those medications.
You have asked any antidepressants and like that or a routine medication you have to take.
Okay.
Drug-induced liver injury can be a possibility. And you have asked about the gait abnormality. What is the significance of that?
And sir, vitamin E deficiency leading to ataxia.
Ataxia. Father expired. You have asked about what is the cause of expiry and
No, sir, I didn't specifically ask about that, but I took the family history of similar illness. It was not reported.
what is the significance of similar history in family?
Sir, usually in Wilson's disease, we get family history.
You have asked any expiry in the family? You have not asked any expiry?
No, sir, apart from the expiry of the father, no other expiry was reported. All siblings are alive and healthy.
Sir, you were examining a 14-year-old child who was not taking complaints not akin to the confidence of the child. You should ask the child कि बेटा मैं आपको एग्जामिन करने लगा हूँ, आपकी माँ आपके साथ है, और if she is not comfortable, you can ask some female colleague. One of very senior professor, she retired professor, was our teacher. He examined the child, 16 years old, the back examination. Child came to my private clinic. तो उसकी मदर ने कहा मैं इस बदतमीज डॉक्टर से कभी भी चेक नहीं कराऊँ. Very senior professor. So what about his vaccination history? He is a known case of chronic liver disease.
So the mother reported she has been vaccinated according to EPI with proper card. So vaccination against hepatitis B is done.
What about A?
Sir, in EPI, A is not covered.
So you have to ask
Okay.
why it's important.
Sir, hepatitis A can lead to chronic cholestatic syndrome, but less likely it can lead to chronic liver disease.
Because she has underlying liver disease. If she will develop hepatitis C, she will go into the hepatic impact straightforward. And same is the B. We have to check the level of the B. What's the antibody level? Is properly vaccinated or not? Or his antibody level is sufficient to it is enough for to cover the hepatitis C. And okay, so how you will investigate?
So first of all, I will confirm chronic liver disease and go for liver function tests, CBC, ultrasound abdomen, or the texture of the liver, and any free fluid in the abdominal cavity. And as I wasn't able to find any free fluid, so otherwise if I would have found, I would have gone for the cyclic tab, but in this case, unable to find. And then sir, cause related, I would go for
But we just summarize your case. Just summarize your history. Just summarize everything.
Alicia, a 14-year-old girl, she is a known case of chronic liver disease and on follow-up in a tertiary care hospital for the past 3 years, now presented with loose motions and currently doing fine. The admission was through OPD. She is, there's no history of any poor school performance, no fine motor or gross motor delays. However, mood swings are reported. There's no history of arthritis, joint swellings, rash, and alopecia. She has been thoroughly vaccinated according to EPI and only one time transfused with the screened blood. The maternal B and C status is unknown and no ear piercings are done. There's no history of previous repeated diarrheas or chest infections and no history of any malabsorptive stools. As far as disease complications, she has repeated complaints of carpopedal spasms and cephalopathy is not reported. The skin is, there is history of dry skin, bone pains, and no bruising or ataxia is reported. No respiratory no bruises or ataxia is reported, and there's no history of respiratory distress as well. Currently, she is taking some oral medications and some sachets. The mother isn't well aware of the prescription, and they are in the past 1 year there have been repeated admissions, increased frequency of admissions, or mainly due to carpopedal spasms, treated with IV medications. And there is no, she is a product of consanguineous marriage with 5 alive healthy siblings, and the father is no more with them. Alright. And no family history of similar illness. And the disease has significant impact on the family and the sibling and the patient as well. Currently, on examination, madam, Weight is between the 25th and the 50th centile. The height is around the 50th centile. She is pale, with not jaundice and no peripheral stigmata of confusion. Madam, sorry. Madam, 143 centimeters. Madam, 14. Liver is, sorry, madam? She is pubertal, madam.
What is the stage?
Madam, I was only able to check for the breast examination, was that it was stage 1, madam. Liver is 7 centimeter below the right costal margin, firm in consistency, non-tender, with a total span of 10 centimeter. Upper border is in the 6th intercostal space. Rounded margins and left lobe is palpable. Left lobe is palpable 2 centimeter in the epigastrium. Spleen is not palpable, and there was no evidence of free fluid in the abdominal cavity. Back of the child was normal, and rest of no, madam, not club. No palmar, no type stigmata of the child. No, madam. Madam, rest of the systemic examination is unremarkable.
Okay.
The rest of the systemic examination was unremarkable, madam.
So what do you think he had? I mean, after somebody say, what did you find the examination, what do you think he had?
Madam, most likely she is a case of chronic liver disease, most likely to be Wilson.
Do you think she had Wilson? Why do you think she had Wilson?
And there is hepatomegaly, and Wilson can present with isolated hepatomegaly as well. With or without.
Most likely she has Wilson. That means हमारे ज़्यादा चीजें in favor of Wilson's हैं तो वो क्या हैं?
Madam, in history I was only able to elicit mood swings,
And that you said she just started puberty and she's a teenager and she's coming to the hospital.
if I could be
आपकी हिस्ट्री से I mean I could ask the crowd, जब वो हिस्ट्री बता रहे थे तो आपको दिमाग में कोई चीज आ रही थी, like you know, was the history good in the sense of the summary के the summary should be कि अच्छा तुम टेलीफोन पे अपने कंसल्टेंट को कुछ बता रहे हो या तुम्हारा जूनियर तुम्हें बता रहा है and you're shaping a case for some diagnosis, कुछ समझ आ रही थी उसमें? Was the summary, in all honesty, the summary wasn't clicking into the brains of the people to make a diagnosis. Summary ऐसी होनी चाहिए कि तुम बताओ इस तरीके से that you lead to the diagnosis which you are going to say. So that's how you influence the examiner also. You know, like my summary should be into, if it's a good differential, then you lead towards the differential. Yeah? Or mood swings are definitely in a teenager, not this indication of Wilson's disease. और कोई चीज Wilson's के लिए?
No, madam, wasn't able to elicit in the history.
Apart from consanguine marriage, consanguinity, yeah?
Yes,
It
and there
could
is no
be a
family,
genetic disease.
no family history as
Okay,
well.
so differential, तुमने कहा chronic liver disease. Tell me the reasons you would say chronic liver disease and not anything else in this patient.
But the illness has been there for a good 4 years, and this shows chronicity, and with isolated hepatomegaly.
Okay.
However, I wasn't able to find any digital clubbing, but you corrected me. Digital clubbing is there. So
If
this
there is
was-
isolated hepatomegaly, तो उसमें आपके chronicity के stigmata भी तो बताओ ना मुझे.
Madam, dry skin and carpopedial spasms, vitamin A deficiency, vitamin D deficiency.
Okay, you think that the carpopedial spasms are due to vitamin D deficiency. Do you see signs of vitamin D deficiency on the body?
No, madam, I wasn't able to listen. The child has been on treatment.
Did she have any fractures?
No, madam, no fracture. The child has been on treatment. She has been taking oral injectables, oral.
What is the other differential of carpopedial spasm? Your child has mainly been coming with carpopedial spasm. Give me the differential of carpopedial spasm then. उसका मेन तुम कह रहे हो आती रहती है इसके लिए, समवेयर हमारा भी फॉल्ट होगा ना कहीं कि हमने कुछ मिस किया है जो अब पिक किया है ये कुछ, बिकॉज रूटीन में आते हैं पेशेंट की कार्बोहाइड्रेट स्पैज्म में जी ये क्रॉनिक कोई ऐसी चीज़ कोई विटामिन डी लगा दो. सो व्हाट इज द डिफरेंशियल ऑफ कार्बोहाइड्रेट स्पैज्म starting from a child, like literally like a 2 years old or a 3 year old, और उसके बाद अब तक क्या डिफरेंशियल होता है कार्बोहाइड्रेट स्पैज्म?
Madam, in a smaller kid, 2 to 3 year old, celiac could be a cause of.
No, I'm not saying the root cause of what happens to the body when you get into a what are the causes of going into a carbohydrate spasm?
Madam, reduced calcium stores lead to.
Reduced calcium stores
Madam, reduced calcium.
in the serum at that particular time. You think the women who are hysterical and breathing fast and actually crying on the funerals are having reduced calcium stores? They also get carbohydrate spasm. So calcium which gets reduced at that particular time in the blood. What else? चलो calcium तो एक हो गया obviously चीज है.
And this is the only thing that is coming in my mind.
Anything
right
else? एल्कलोसिस से तो बेटा उस वक्त वही है ना जो हिस्टेरिकल हो जो आप जिसके लिए आप ब्रीथ फिर बैग में कराते हो वो तो वही है कैल्शियम डिप कर जाता है ना व्हेन यू इंड्यूस द स्टेट ऑफ एल्कलोसिस. कैल्शियम की डिपिंग के फिर आप रीजन बता सकते हो कि एक तो एल्कलोसिस है. व्हाट एल्स? देन यू कैन गो इनटू द डिफरेंशियल ऑफ व्हाट कॉजेस द डिपिंग ऑफ द कैल्शियम. Is it a chronic calcium deficiency or is it an acute state which is created due to what? One is alkalosis due to hyperventilation. What else?
Nutritional rickets can also lead to being.
Okay, I mean yes, but you know nutritional rickets के patient आपको उस वक्त नहीं हो रहे होते कार्बोहाइड्रेट कब होते हैं हमको?
But during crisis, any crisis.
Once okay, if they come in with diarrhea and a crisis or when you're rehabbing them, okay, that's when everything starts moving intracellular and they start showing you the techniques. They generally would be running around with their nutritional rickets and then either during an episode of acute severe diarrhea they would get the carbohydrate or when you are rehabbing them in your ward and they're getting better and then things start moving intracellularly and you start, you know, bones बन रही हैं आपकी body ठीक हो रही है, this start showing you technique. But what I'm saying is वो कह रही है एक तो एल्कलोसिस होता है हाइपरवेंटिलेशन से और भी किसी तरह यू हैव टू आप सारी चीज़ों में टिक तो करो ना फिर अगर आप बताना चाह रहे हो तो और किन वजूहत से आपका ट्रांजिट हाइपोकैल्सीमिया हो सकता है एक्यूटली. एक तो कह रही है एल्कलोसिस किसी और वजह से भी हो सकता है. When your kid is vomiting a lot, what do you get? What kind of electrolyte imbalance comes?
Metabolic alkalosis.
Oh well, okay. What is the other thing? You know, आपकी किडनी ने जो स्टेबलाइज करना होता है तो व्हाट इज अदर थिंग दैट इसके साथ ही चेक एंड बैलेंस हो रहा होता है. रेनिन-एंजियोटेंसिन इज नॉट गोइंग टू कॉज हाइपोकैल्सीमिया. आपकी हाइपोकैलिमिक स्टेट्स भी तो होती है ना. यू कॉरेस्पॉन्डिंगली हाइपोएल्कलोसिस हो जाता है, यू हैव हाइपोकैलिमिया विद द वॉमिटिंग, you lose your hydrogen as well and you go into a tetany. Okay, that's the one thing. हम क्रॉनिक की बात कर रहे हैं ना कि क्रॉनिक स्टेज की आप बात अभी कर रहे थे वो तो आपको उधर ले गए ना बिकॉज ऑफ हाइपरवेंटिलेशन व्हेन यू सेड यू क्रिएट एल्कलोसिस एंड यू कैन हैव दैट. व्हाट आई एम सेइंग इज anything else apart from calcium which can cause tetany? If a little baby has hypocalcemia as in fitting away, हमने आपको पढ़ा the other day did you present that case वैसे? अगर आपका बच्चा कन्वर्स करे जा रहा है, आपका कैल्शियम 5 आ रहा है, आप दिए जा रहे हो कैल्शियम, छोटा सा बेबी है 1 साल का, what is the other thing you do?
Dilute hypomagnesemia.
Exactly, you must do your magnesium. So yes, so magnesium के low levels भी tetany करते हैं. Magnesium बिल्कुल उसी तरह एक्ट करेगा जिस तरह आपका कैल्शियम एक्ट करेगा. So she could have hypomagnesemia. So if you discover that about this kid, फिर किस if she has hypomagnesemia, so then the examiner could ask you what are the causes of hypomagnesemia in a child. It's not necessary कि मैं तुम्हारे पास एक liver enlarged लाती हूँ तो I would ask you all the differential. तुम्हारी main complaint इसकी tetany carbohydrate spasm है. The examiner is going to take you along that tangent because this is an FC-based exam. He might not ask you much about that liver. And so you said the main complaint is carbohydrate. You said vitamin D deficiency. Then we said कि उस macronutrient की इसको visibly कुछ नजर आ रहा, but yes. And what is the other? तुमने alkalosis की बात की तो उससे मुझे ख्याल आया. During treatment, what treatment causes the side effects of causing tetany in this patient of chronic liver disease? अभी जो हम बात कर रहे थे. Could she be on some therapy that जो CLD वाले patient ले रहे होते हैं which will cause alkalosis and tetany? अब तो मैंने clear cut MCQ बता दिया. Anybody?
Chelation therapy.
Chelation therapy? Why would it cause alkalosis and?
Well, I'm not sure, but it's also a bivalent ion, so probably due to poor stores it can.
अगर वो करेगा कुछ तो फिर तो वो acidosis करेगा renal tubular, but no, it doesn't cause alkalosis. Know your biochemistry, na? Why would we give bicarb therapy to this patient? To create a state of alkalosis to the point of tetany, मेरा बच्चा. What about आपकी इसको ascites नहीं मिली जब आप diuretic देते हो like laxerites, Lasix देते हो, hypokalemia करते हो, alkalosis करते हो, you shift your ions and they will come to you with actually tetany. क्योंकि आपके vitamin D stocks तो वैसे ही कम होते हैं, तो आपको chronic liver disease के बच्चे को carpopharyl spasms होने लग जाते हैं. Because you are giving them a significant amount of diuretic. You did not find ascites, but you don't know she might be on therapy. That might be one cause and we need to look into that. What are the other causes of, मैं तो कहती हूँ she has hypomagnesemia. So tell me the causes of hypomagnesemia. तुमने बात की जब magnesium की, तो आपका examiner कहता है hypomagnesemia किन causes में होगा? कोई idea है?
Madam, malnutrition secondary due to the disease can lead to poor stores of magnesium in the body.
Does poor store of magnesium happen just like that, like vitamin D? मतलब does it happen? What are the states where आपका magnesium कब कम होता है? Start off. People, किन causes में hypomagnesemia होगा?
Malnutrition.
Malnutrition?
Malnutrition, madam.
Malnutrition due to?
Madam, in this
chronic
case,
diarrhea maybe, okay? States of chronic diarrhea where you lose the magnesium ion. So pure malnutrition, it's more likely to cause a low phosphate, a low calcium, less likely to cause a low magnesium to the point of having carpopharyl spasms. But if you're having chronic diarrhea, yes. In a state of chronic diarrhea and malnutrition, yes, you could have hypomagnesemia, right? So chronic diarrhea. What else? Chronic diarrhea would be a very important differential, okay, to cause hypomagnesemia. What else? कोई cause नहीं है?
Beetle man, man.
Okay, if you can put it under the big umbrella of if you are losing it from the kidney, okay? Kidney is a big source where if you don't conserve magnesium, you might be having a problem. So you could have a congenital state where you're losing magnesium, or you could be on some drugs which are causing it. And what is the other way that you could lose magnesium, or some other drugs which you might be giving to the patients for long term and cause hypomagnesemia? जो आप बहुत यूज करते हो नहीं वो बेटे अब लॉन्ग टर्म तो नहीं यूज करते ना. इट्स नॉट लाइक यूर ऑन सेफ्ट्रोक्सोन फॉर इयर्स, दो इट कैन हैपन इन पाकिस्तान आई गेस, लेकिन वैसे सेफ्ट्रोक्सोन तो इयर्स के लिए नहीं मिलती. मंथ के लिए कौन सा आप दे देते? ओके, प्रोटीन पंप इनहिबिटर्स लाइक जो आप यूज करते हो सारे मैकेनिज्म ब्ला ब्ला, and they cause a significant state of hypomagnesemia. Okay, so they can cause carpopharyl spasm. But the most important thing which everybody is highlighting to you is the kidney, the loss through the kidney. So you think she could have something where she is losing from the kidney, the magnesium, or she might be on some medicines which are causing. So clearly there is more to her than just because you wouldn't be expecting her to come in 2 to 3 times with carpopharyl and we were not able to immediately solve out the issue. So it must be more than just a simple thing. Okay, so it might be that she is having a renal defect as well.
Pancreas-like
Well,
syndrome.
seriously, that causes more of what kind of iron losses, people? The kidney people are sitting here.
Madam, pancreas syndrome.
No, he's saying कि जिस वक्त आपकी kidney, he's talking about the proximal tubular.
Yes, madam. Amino acid urea, glycosuria,
Okay, so what
phosphaturia.
your friends are highlighting to you is it's more to do with the distal tubules, your magnesium. So unless and until आपका वहाँ पे problem होगा, so वहाँ पे आपकी ज़्यादा, the phosphaturia, the bicarb loss, the amino acids and everything, you're losing out in them rather than the magnesium. You need a damage a little distal to that. So you could have a congenital defect or something other than that. So उसमें हो सकता है. Coming to the kid, मतलब आप लोगों को जब आप एक symptom present करते हो ना अपने examiner को, तो examiner is going to ask you the differential of the presenting complaints as well. You seem to think कि GI का केस आया और उन्होंने हमसे chronic liver disease से पूछनी है. आपकी presenting complaint है carbopetal spasm जिसके साथ आ रही है. आप मुझे कह रहे हो reasonably thriving है, puberty भी start हो रही है, pubertal moods भी उसके हो रहे हैं. इतना बुरा हाल नहीं है, grade 1 clubbing है, लेकिन liver firm है. So you're going to talk about why she has carbopetal spasm and the isolated hepatomegaly that she has. You cannot find evidence of portal hypertension in this case, isn't it?
Yes, ma'am.
And you really can't find an evidence of significant impact, very severe impact on her health from the chronic liver disease that you are telling. So उसके अंदर differential क्या होगा फिर? अगर she says got this, you can't find an evidence of portal hypertension, no severe advanced CLD, she's not cholestatic, she's not grade 3-4 club, she's not pruritic, and she hasn't had any neurological evidence of anything. अब बताओ कि क्या आप सोच सकते हैं इसके लिए?
And xanthelasmas are also there under the eyelids. So it was an additional evidence.
Okay.
Additional evidence.
She does. अच्छा मुझे यहाँ से नजर नहीं आ रही. Okay. All right. Okay. That's some very important finding. So what could she have? Because if she has them in isolation with chronic liver disease की किन chronicity chronic liver diseases के साथ associated है xanthelasma, and which does not fit into her. What do you need in CLD really chronic liver disease कहने के लिए by way of other differentials of liver disease? There is liver disease and then there is chronic liver disease. Okay, so you can have just liver disease per se, and she's not very bad advanced chronic liver disease. Okay, metabolic liver diseases may not be chronic in that sense of liver disease. तो आपके xanthelasma generally किन CLDs में आपको मिलेंगे जिनके साथ क्या associated होता है?
Madam,
Yes, somebody said that. Yeah, you expect cholestasis, and she has no history of jaundice,
Yes.
and she's not jaundice right now. So you don't. Normally you expect cholestasis in xanthelasma. So if you have xanthelasmas on their own, and you have an isolated hepatomegaly, and you can't find evidence of significant advanced chronic liver disease, what is the associated liver disease now? People? Connective tissue xanthelasma.
connective tissue तो
नहीं
नहीं.
समझ आई इस बात.
Genetic.
नहीं कुछ maybe I'm missing out on something. आप किस disease का सोच रहे हो? लेकिन what about glycogen storage disorders? Okay, you could have hyperlipidemias in them and not have very bad liver disease to begin with at that time. So you could. It's just a theoretical possibility, not that she has it. Okay, so if you notice xanthelasmas, or if you have what kind of a disease where you can have hepatomegaly and significant, then these kind of, you could have those due to cholesterol, the xanthomas or the xanthelasmas, वो किसमें होगा? But उसमें तो jaundice होगा ना. When you talk about biliary cirrhosis, you've got to have cholestasis. There is no biliary cirrhosis without cholestasis, no? You need that jaundice.
But generally in chronic liver disease, due to reduced production of lipoprotein, cholesterol metabolism is somewhat
What genetic
compromised.
conditions would have a hepatomegaly or even a bit of a splenomegaly, not advanced chronic liver disease, but have xanthelasmas?
Metabolic syndromes, yeah, hyperlipidemia.
Okay, which have, yes, okay, which hyperlipidemias?
Madam,
Liver protein lipase deficiency,
uh,
could you have that?
madam, yes, could be a possibility.
They could have hepatomegaly, bit of splenomegaly, but that generally, actually their splenomegalys tend to resolve with age if you treat them, but they can have this liver and spleen and have the signs of hyperlipidemia on their body. So you could have that and have some hepatomegaly. You could have hepatomegaly as a fatty liver if she has lipid profiles which are abnormal. There are many syndromes which have higher raised. She doesn't fit into the syndromic conditions, but do you know of any syndromes where she could have a significant hepatomegaly as an isolated thing with signs of lipid hyperlipidemia on her skin and her joints?
And usually the kids are more of obese in those cases.
Seriously?
She's a thin and lean build.
So in the congenital hyperlipidemias, you expect thin and lean fat kids?
No, but not in congenital hyperlipidemia.
You know,
But,
would you get xanthelasmas at her age in a fat child because he has exogenous capacity?
no, madam.
Would you have that?
No.
Madam,
Even if they have a big fatty liver, I mean, fatty liver, non-alcoholic steatohepatitis, NASH, what we call it, is a very significant thing now in teenagers who are obese. But you do not expect skin signs of it. Remember that, because you would get that only if they have significant hyperlipidemia, and in pediatrics, that would almost 99.9% be congenital cause. Okay? So it has to be either a syndromic one or a non-syndromic one, like a lipoprotein lipase or other various hyperlipidemias, and out of which the hypertriglyceridemias tend to have a enlarged liver because they cause a fatty liver. The autosomal dominant hypercholesterolemias, surprisingly, they do not have a very big liver because उस तरह का fatty liver नहीं होता ना, जिस तरह का आपका chylomicronemia और इनमें होता है. They do get a fatty big liver. What else? Any other differential you guys can think of? Like अगर हम कहते हैं she doesn't have advanced CLD, doesn't have portal hypertension, फिर आपके सारे causes of CLD बाकी भी आएंगे. You can quickly enumerate, so you should never say को मुझे कोई significant कोई criteria ऐसा नहीं मिल रहा to fit into say कि ये Wilson's है और कोई, but you can say chronic liver disease के common causes ये हैं. Then what are the common causes quickly? And then we should close it off. It's 9:20.
Wilson, autoimmune, B and C.
C, seriously? B, yes.
B.
Yeah.
And
C, you wouldn't see at 14 years
Yes, madam.
with advanced liver disease.
late presentation. And madam, other metabolic causes like alpha-1 antitrypsin, although it's rare. but-
Exam में कह दो, because your examiners are not aware that we don't have it in much. Almost, we have only one reported case in years and years. So yeah, but examiners don't know that. कह दो और.
Cystic fibrosis can lead to.
But she doesn't have lung disease.
Yes.
आपने इस
Doesn't.
patient का differential
Okay.
बताना है, not a wide differential of chronic liver disease.
Okay.
She has, even though you might have variants of cystic which do not have bad lung disease, and they have exocrine pancreatic insufficiency, bit of lung, having a liver enlarged, but the bit of lung has to be there at 14 years for her to have a history. कुछ तो हो ना उसके अंदर, अगर कुछ भी नहीं है तो नहीं है. हाँ.
Routine medications.
Drug induced, you could say, yeah, you could say that she has drug induced. Then also drug induced हो गया, ये हो गया, or anything else, any storage, metabolic storage. So you talk about lipid storage, you talk about,
Glycogen
lipid
storage
storage
type
नहीं कहना
4.
चाहिए, hyperlipidemias or the glycogen storage disorders, or what else?
And glycogen storage type 4 can lead to liver disease.
Type 4 के अंदर अब तक, yeah, well, she would have some level of significant liver disease by now. The variant which would have them living till now would still have significant liver, when the type 4 is a bad liver disease. ठीक है, उसके different variants हैं, and many would die in the first 4 years of life. Many would die, and the ones who would be there would have significant advanced liver disease. So, she could be type 3 GSD. Okay, a firmer liver, a type 3 GSD, a type 9 GSD. So you could have a firmer liver in the type 9, a further. So you could have a glycogen storage disorder over here, or you could have any other genetic disease of the liver. Any? Okay. There are many mutations or genetic diseases which cause, you don't need to know them. She has one of them, but you don't need to know them because you are an FCPS. But she has a large mutation positive, and so liver is part of it, and kidney is part of it. So she's probably losing some magnesium from the kidneys as well. So large mutation is very different phenotypes, but आपको उसका पता होने की ज़रूरत ही नहीं है for your FCPS. But she has one of the genetic diseases. But you should be able to tell that, and you should be able to tell about the causes of carbohydrate, what can cause them, what, और उसको हर tangent पे वो लेके जाए तो आपको अपने electrolytes का पता होना चाहिए, आपको biochemistry का पता होना चाहिए, interpretation of labs पता होना चाहिए. Anything else? So we should stop at this. Any question, query remaining?
Examination में we have just left lobe of liver and she has not done just as well. So why shouldn't we keep the differential of Budd Chiari?
Yeah. So उससे डिटेल में आप Budd Chiari का कोई और साइन अगर उसमें नहीं है, that she doesn't have visible veins in the top or the back, और उसके अंदर portal hypertension का evidence नहीं उसको नजर आ रहा है, he can put it at the bottom of the differential because that's vascular occlusions. अब वो तो there is so much other things which we didn't discuss as part of chronic liver disease, that it's almost 9:30. We could go on. इस तरह तो बहुत सारी चीजें हैं. But yes, उसमें visible अगर आपको evidence कोई नजर आ रहा है तो will become a topmost. because bud CLD by per se is a vascular obstruction. So you do have visible veins in the upper territory. You will have a caudal lobe which is hypertrophic. You might have back veins. You will have some ascites. And so portal hypertension is the reason they come to you. They don't come to you with an isolated hepatomegaly. They come to you, they present because they have portal hypertension. And do remember that the great majority, overwhelming majority of pediatric liver disease comes to you with portal hypertension. Unlike adult liver disease which will come to you with raised bilirubin. Adults आते हैं थोड़े जॉन्डिस के साथ, थोड़ा हेपेटोमेगाली के साथ, so आपको स्प्लीन भी मिल जाए. Pediatric liver disease, overwhelming majority comes to you with evidence of portal hypertension. That's the way pediatric liver disease is.